Okay. Good afternoon, everyone, and welcome to the third lecture of week 4 of the certificate course. Today's topic is HIV epidemiology, prevention, and oral TDF containing PrEP study in India by Dr. Seema Sahay. Dr. Seema Sahay is a scientist, is an anthropologist, and she has completed her master's and doctorate from Department of Anthropology, University of Delhi. She has completed postgraduate diploma in bioethics from National Institute of Epidemiology, Chennai. She has been working at ICMR, National AIDS Research Institute, ICMR Nari, Pune since 1999 as a socio-behavioral scientist. Currently, she is the director in charge of the institute and leading the division of social and behavioral research sciences as head at ICMR Nari, Pune. During her past 22 years at ICMR Nari, her focus of research has been largely in the large-scale qualitative, quantitative, and mixed method studies on HIV prevention and care among key population, HIV and TB vaccine trials, prevention trials, PrEP demonstration, adolescent reproductive, sexual and mental health, HIV disclosure, policy research, domestic and intimate partner violence, community engagement, prevention and control of Japanese encephalitis in North India, biomedical HIV prevention interventions, and COVID-19. Dr. Sahay has led and coordinated the community participation and engagement for clinical trial unit, HIV vaccine trials, and microbiocide trials. She has developed and led the community involvement plan for clinical trials such as HIV vaccine microbiocides and HPTN. She led the study on preparing the site for conducting effectiveness trials of microbiocides. She has expanded her research area to rural India, where she addresses the emerging needs of HIV-infected individuals, the reproductive health needs of female sex workers, and biomedical HIV prevention interventions. Currently, she is developing a cohort of HIV uninfected female sex workers in rural settings. She has extensively worked on community engagement for the prevention and control of JE or AES in Gorakhpur and adjacent villages in Uttar Pradesh. She is leading and implementing the PrEP demonstration study among MSM and TGW population in Pune and Jalandhar. She is also leading the community preparedness and participation for TB vaccine trial. And her recent studies have also included COVID-19 surveys for COVID-appropriate behaviors and stigma and discrimination studies among COVID survivors and the affected family members. Dr. Sahay has developed and evaluated the mental health assessment tools for HIV-infected individuals and developed culturally tailored tools to measure and prevent domestic violence and intimate partner violence in India. She has written educational modules on adolescent reproductive and sexual health education, ARSHI, community engagement module for JE or AES prevention and control, and Fly High Together for prevention of intimate partner violence. She has contributed to guidelines and modules developed for COVID-19 patients, the family members, and healthcare providers. She has ongoing and completed over 38 multi-centric projects that have established national and international collaborations with the National Institute of Epidemiology, Calcutta University, Krishna Institute of Medical Sciences, Deemed University, KLE University, KGMU, Lucknow, AIMS, Bhopal, RMRC, Bhubaneswar, World Health Organization, Emory University, National Institute of Health, Family Health International, International AIDS Vaccine Initiative, Department of Science and Technology, Bill and Melinda Gates Foundation, Department for International Development, and various NGOs, CBOs, working with key population in Mizoram, Chennai, Punjab, and Mumbai. Academically, she is recognized PhD guide in anthropology and health sciences at Pune University and Symbiosis International University, Pune. She is also a guest faculty of KLE University, Belgavi. She has mentored master, doctoral, and postdoctoral fellows. And in addition, she has mentored Fogarty Global Health Fellows and NIH trainees. She is an editorial board member of the Journal of International AIDS Society and academic editor of PLOS Plus One. She has over 89 publications in various national and international peer-reviewed journal and book chapters. I'm really honored, ma'am, to have you today here with us for this topic, which actually needs somebody who has done a deep research. I will request now Dr. Seema Sahay to please begin the session. Over to you, Dr. Seema.
Thank you for the kind introduction and a big introduction, Dr. Renu. I'm really, okay. I hope I do justice to what I'm going to talk about. Shall I project my presentation from here? Am I audible?
Yes.
Is the screen visible to all?
Not yet, ma'am. Just
now.
No, not yet.
But this is the only way it is.
Ma'am, can you try? Ma'am, can you try with share your screen instead of a window or a tab?
Okay. No, it's not coming.
All right. Ma'am, can you see there's a hand at the end of the screen? Beside that, there's a present now option.
Where?
At the end of your screen, where we mute or unmute, in the same line, the fifth option. Present now, beside the hand.
Yes.
Yes.
And in this, it is coming as your entire screen, a window, a tab.
Yes. You can try your entire screen.
But the entire screen is not.
Ma'am, you will have to click on the screen and click on share.
But it wouldn't share.
Yes, now it's sharing. Now you have to open your PPT. We can see your screen, ma'am. You will have to just click on the PPT.
Can you see?
Yes, yes, it's perfectly visible now.
Now?
Yes.
Okay, thank you.
All right.
So as Professor Renu, first of all, I would like to thank Marathavar Mitra Mandal, Shankarrao Chavan Law College for inviting me and helping me in giving this particular presentation. And I'm going to talk about HIV epidemiology. And Professor Renu has been very kind in inviting me for the last 2 lectures also, and I could see that all of you, all the students have learned a lot about the risk behaviors and the problems that is faced by the community. So I will straight away talk about the epidemiology of HIV. So just to give a brief introduction about HIV, you know, HIV is the virus that causes infection. So yesterday, Dr. Pawar was saying that there is a difference between HIV and AIDS. So this is a difference. HIV is the virus, and AIDS is the acquired immune deficiency syndrome, which is which comes at the advanced stages of HIV infection. All of you, any one of you can stop me in between if you want to ask question in between also. So now coming down to the transmission, first of all, we must know how HIV gets transmitted. There are just few modes of transmission. It is by having sex and sharing injections, particularly the needle, with someone who has HIV. And we have to remember, we do not know if there is no other symptom of HIV. You cannot recognize a person who has HIV. So basically, there are tests available, and with the blood test only, you get to know a person who has HIV. And that is why prevention, protection is extremely important, because you do not know the person in front if you has HIV or does not have HIV. The second mode of transmission is from mother to child during pregnancy. It can also be, and this transmission is to the unborn child. The virus can get transmitted during labor or delivery, during breastfeeding also. But there are HIV medicines that can reduce the risk of HIV transmission, and that is going to be the focus of my talk today. Then you also heard about antiretroviral therapy, and antiretroviral therapy is nothing but a group of medicines that are given to the patients who are diagnosed as HIV infected. And since it is a combination of HIV medicines, that's why we always call it as treatment regimen. ART is recommended for everyone who has HIV, whether you have a symptom or no symptom. Once diagnosed, a person should get HIV medicine, which means ART. One thing that we need to remember, why HIV is still a big problem, it is because it is still incurable. You have medicines to reduce the level of virus in the body, the viral load, but you cannot completely remove HIV from the body. And that's why it's an incurable and disease, but it is also a manageable disease now, thanks to antiretroviral therapy, which is available, which makes a person live longer with a better quality of life. Another good thing about ART medicine is that it also reduces the transmission of HIV to any other partner, or whatever way the transmission can occur. So a person who has HIV infection, if he or she is on ART, then their viral load goes down, and it goes down to the level that they become less infectious. And that is why even for the prevention, ART is extremely important. And this kind of prevention is also known as positive prevention. This is a busy slide. I'm sorry for this. I can share this slide later on. But this whole slide is a very nice slide which covers the history of HIV right from 1981 to 2021. I have put circles on the major things that I would like all of you to focus on. In 1981 in US, people realized there is something new. But at that time, no one realized, because there was some young men who had Kaposi sarcoma, which is skin cancer, and this kind of cancer was actually seen in very old patients, geriatric patients, because it is a disease when your immune system goes down. So young people are very strong, and getting this kind of, and the recurrence of recurrently a doctor was getting patients from a particular area, young men who had Kaposi sarcoma, and that rang bell, and it was informed to CDC, Center for Disease Control, in 1981. And by 1982, there was alarm, and acquired immune deficiency syndrome was defined. So here it is, the history, 1982. Then I would like you to come down to the test, because there were not many tests available. So in 1985, first antibody test came up. And again, I saw yesterday the graph was shown to you, and when the test would you would get to know you are HIV positive is not immediately. So immediate exposure to HIV does not mean that you will get tested. And that is where counseling became extremely important. So it became voluntary counseling and testing. So in 1985, ELISA came into picture. Later on, PCR came into picture. Western blot was there. So many tests came into picture, and diagnosis was possible. Then I want you to focus on 1994 and 1998, when mother-to-child transmission. So the drugs became available. Zidovudine became available, and mother-to-child transmission was like scientists were able to really reduce the transmission from mother to child. So there is a lot of control when there is a pregnant woman who has HIV, and if she is given antiretroviral therapy, the doctors can control the transmission of HIV to the unborn child, this is called as and because initially it was called as mother to child transmission, but later on it is not like mother is only responsible for HIV. So it came to be parent to child transmission, child transmission. So it became PPTCT program later on. Then with this, I have also written here and JIPA. So here the significance of community came into picture. So HIV and AIDS is a disease. It is more of a social disease than a biological disease. And here it's a big example. Now AIDS is under control. So it's a big example where community itself, the patient itself, or the risk group itself became part of the whole movement of controlling and preventing HIV. And this is called as greater involvement of people living with HIV and AIDS. And this is known as principle of JIPA principle, which was very helpful for many diseases. Even now in COVID, people are asking how community got engaged, because when community does not believe in something, nothing can happen. You have a best formulation, best drug in your hand, but if the community does not take it, the patient does not take it, patient does not adhere to it, it is useless. So involvement of the community, the stakeholders became extremely important, and we learned this lesson through this AIDS response. Then I would come down to this area of 2007, when male circumcision was found to be protective for men, and it was also tried in India, but India there was great resistance, so male circumcision was not rolled out. As you know, ART is rolled out. ART is now available free of cost at the ART centers everywhere in the country, right to the remote village. So anyone who is HIV infected or feels that he or she is at risk, they can go to any of the recognized government ICTC, which is Integrated Counseling and Testing Center. There they will get counseling also, and then if required, they will get free testing also, and it is very confidential testing. And after testing, if somebody is found HIV positive, then they are also sent to free ART rollout program at the ART center, and they get ART center. So universal access was also one of the AIDS response which helped in controlling HIV/AIDS. So in 2007, you see it is male circumcision that came into picture, and because of our own community and cultural reasons, we were not able to roll out as available free of cost for everyone, or anyone would come in the government. But WHO had recommended that. In 2009, we also found, initially, what used to happen? When HIV infects somebody, then your CD4 count, the CD4 count goes down. And CD4s are the cells, they are the fighter cells, and antiretroviral therapy really works on them. So initially there was some kind of tab, like if you have a CD4 count of 500, then only you would start getting antiretroviral therapy. Initially it was 1000, so something like that was there, and slowly, and so people would wait. So one used to be HIV positive, and then they would wait for their CD4 count to come down, and then ART would be prescribed at the required guideline. But in 2009, there was a study called HPTN 052, where it was found that ICMR Nari also participated in this particular trial. We did this trial, and we found that early ART is very useful in not only helping the HIV patient, but also in preventing the secondary transmission, which means transmission to the partner was also getting reduced by giving early ART. And early ART would mean CD4 count much higher than what was prescribed at that time. So it is, in this time it was early ART, but as you see here, 2016, now we know that it is only test and treat. So straight, you don't wait for CD4 count to go down, because ART is so good that the moment you get diagnosed with HIV, you should be on ART. So that this test and treat has started from 2016. In our country also, we are using 10 and 2013 is the focus on prevention. Here you see it's written PrEP, pre-exposure prophylaxis, on which I'm going to focus my talk on. So there were trials, successful trials, where antiretroviral tablets were used to just prevent HIV infection in uninfected individuals. So all healthy individuals, but at high risk of HIV infection because of their behaviors. In them, these tablets were found to be very useful in helping them not to get HIV. So PrEP became very important, and in 2013, PrEP was actually approved for use by HIV negative people world over. So this is the kind of history in just 40 years of the AIDS response. Now coming down to the epidemiology of HIV. So we should know the numbers, how numbers are coming up, because that helps us understand the extent of problem that we face, and the extent of problem we are into, and the need for interventions that we need to prevent or control the disease. So if you see adults age at the globe, this is, I'm talking about the world. So adults age 15 and over 15, so there are around 36 million adults who are age 15 and over living with HIV. Among these, 19 million are women and 16 million are men. Children aged 0 to 14 years who are living with AIDS is 1,700,000 children who are living with HIV. Now coming to, if you see this bold one, the HIV prevalence rate. So prevalence is something like this, that if you sit here, if you are sitting in a room, and if I try to test all of you at a given point of time, and then I find out of, suppose 100 people are sitting there, and out of 100, 2 persons have HIV infection. So that is called as prevalence rate. So it is always like here we have 2% prevalence rate if 2 in 100 are there. So in all over the world, the prevalence rate is among adults is 0.7, among women it is 0.8, and among men it is 0.6. So prevalence gives you a cross-sectional idea. So what is existing right now? What is the pool which is existing right now? So HIV prevalence among young women is 0.4, HIV prevalence among young men are 0.2. Then comes another thing. Children and adults newly infected with HIV. So when I talked about prevalence prevalence means we are talking about the pool of people who are there, who already have HIV infection. But in this pool, new people will get added, who will acquire infection newly. So that is called as incidence. So if you look at the incidence, adults and children who are newly infected, you see the numbers. I'm showing these numbers here. 15 million newly infected HIV adults and HIV. You can see that. So basically, if we come down to the see here, it is the last row. It is HIV incidence per 1,000 population is 0.19. It is still very high. If you translate it into numbers, it becomes millions. So new infections are getting added. So prevalence will keep on increasing. Sometimes prevalence will stabilize also because people die also. So within that pool, if people die and new infections get added, the numbers might not change also for prevalence. But incidence is a very good estimate. If you can get incidence, but getting incidence scientifically is very expensive and very tough job. So it is generally estimated incidence that we show. India, what is the prevalence scenario in India? So if you see the graph on this side, left side, from 1987 we had a peak around 2002, 2005, and it has started coming down till 2020. So our adult prevalence is 0.22. So if the HIV is estimated, and we always call it as estimated prevalence. So in a cross section in the country at a given point of time, we have 0.22% of HIV prevalence. And this is 2020 data from NACO, National AIDS Control Organization. And if you look within the adult prevalence, males, it is 0.23% and females, it is 0.20%. Statewide also we have HIV prevalence data from NACO again. This is taken from National AIDS Control Organization technical report. And you see here this circle. So you see India. So this is our national prevalence 0.22. And on the left side you see they are more than our national prevalence. So in Mizoram, Nagaland, Manipur, Andhra Pradesh, Meghalaya, Telangana, Karnataka, Delhi, Maharashtra, Puducherry, Punjab, Goa, Tamil Nadu, the prevalence is higher than the national prevalence. And on the right side of India, you see their national prevalence, the prevalence in those states, it is lower than the prevalence. So this is how interventions would occur according to the prevalence. For example, you see in Mizoram, it is 2.37 as compared to 0.22. In Nagaland, it is 1.44 as compared to 0.22. So the national prevalence is important to give us a picture of this comparison, and accordingly, the government has programs. So programs are not very arbitrary kind of thing. It is based on evidence. So, and this evidence is generated by the National AIDS Control Organization in India. So in India, what incidence that we have been seeing since last 10 years. So this is where you need to focus. We are seeing 56% decline in last 10 years, which means the interventions, the programs that are there for HIV prevention and control, they are working. They are successful because we are seeing this kind of decline. And right now we have estimated 23.19 lakh people living with HIV in the year 2020. Now, why I'm talking about MSM and men having sex with men and transgender women? The estimated median prevalence in MSM ranges from 5%, this is global, 5% in Southeast Asia to 12.6% in Eastern and Southern Africa. So just imagine the prevalence you saw in India, it is 0.22. So 0.22 is general prevalence. And if you look at MSM and TGW in India, it is 4.4% in India for MSM, and for TGW, it is 8.8%. So just when I showed you the state-wise difference, look at the population-wise difference. So we are concerned about this particular vulnerable key population. So according to UNAIDS, MSM accounted for 44% of new infection in Asia and Pacific, which is again alarming. So almost half of the new infections that are occurring in the world is, not in the world, but in Asia, is from MSM. And this is data just to not to be pointing any kind of fingers. I really want to say it upfront. It is just to bring out the matter of concern and why we need to really have good interventions for this particular vulnerable population. So if you see the risk is of acquiring HIV is 26 times higher in MSM as compared to general population. So now you see why we are focusing on MSM. Again, the risk is 48.8%. This data is from 15 other countries for the transgender women. So this is why this population, these two populations are extremely important for our country also, because they need good interventions and be protected from HIV. Then there are many reasons why this particular population is vulnerable to HIV, why this risk is there. So there are biological reasons, there are psychosocial reasons also. Psychosocial reasons I have been hearing since last 2 days. I know all of you are a learned group, and you know there are very lot of psychosocial reasons. So MSN and TG women, they form a diverse group in terms of behaviors, identities, and healthcare needs also. They, as you saw earlier from my earlier slide, the risk is 26.6%, 48.8% of HIV STI acquisition world over. In India, the prevalence is very high in MSM and TGW group. And the reasons are unsafe practices, including condomless sex. And that is not just because they want it. Sometimes it is an issue, it's a problem. They have multiple partners, anonymous partners with unknown HIV status, concurrent partner, lack of knowledgeable healthcare providers who do not know. Yesterday, Madam was really talking about how the capacities of the healthcare providers have to be built to really, so that people, this particular community, this vulnerable community, could easily come to them and have access to healthcare and health education also. And there is lack of cultural competence among healthcare providers. So they do not know the community, they do not understand the community, they stereotype the community, they stigmatize the community. Probably that could be one of the other reasons. Some biological reasons are like receptive anal sex. Risk of acquiring HIV in receptive anal sex is higher than the receptive vaginal sex, because there would be more wear and tear. Then there is lack of awareness of consequences of HIV infection. What can happen with HIV infection and why they can get it. If you have STI of much more higher risk of acquiring HIV, that is there. Then there is low awareness of appropriate prevention of HIV. How can you prevent? Condom is one way. But if you don't want to use condom because of various occupational reasons, because of your own behavioral reasons, then there is PrEP, pre-exposure prophylaxis, which is available now. There are post-exposure prophylaxis medication, which is required in case of emergency, but there is less awareness about them. Then lack of knowledge about use of condom, when to use it, how to use it, and how to correctly and consistently use it, that is there. Criminalization, I have been hearing about it. Criminalization of homosexuality and substance use is very much there, and that is why stigmatization is there. Then lack of awareness about self-diagnosis. Self-testing is now getting available, but self-diagnosis, nobody would come. And once there is no HIV diagnosis, there will be delay in treatment initiation. And that is why there would be more of secondary transmission plus AIDS. That is going to happen if the diagnosis is not done as soon as possible. And now there are guidelines, the test and treat is the guideline. So immediately if diagnosis is done, it is the best way. They can be linked to the ART center where they would get free ART. But that knowledge, that information with everyone might not be there. there are various. Then now, how to prevent? Treatment is available, although not the cure, but treatment is definitely available, and a patient can have a very good life, a good quality of life if he or she is really adherent to the ART. But there are various HIV prevention modalities that are available right now. They could available or in the research pipeline also, like preventive HIV vaccine. If they are there, if vaccines are there, vaccines can help you fight any acquirement of disease. So you will not be able to acquire any disease, particular. For example, if you have taken polio vaccine, you don't get polio because you have taken that vaccine. Same way, had there been HIV vaccine, it would have been a boon for us. But HIV vaccine is a far off dream right now. Then oral PrEP, injectable PrEP, pre-exposure prophylaxis. They are getting available now. Post-exposure prophylaxis is definitely there with us. Now coming down to preventive vaccine, vaccine is given to people who do not have HIV with the goal of preventing HIV vaccine. It reaches a person's immune system. It will effectively fight against HIV in case that person is really exposed to HIV. So if there is unprotected sex. But currently we do not have HIV vaccine. India has conducted 2 HIV vaccine trials. Both of the trials were conducted by ICMR NARI. I was very much part of it. But those vaccines were safe, but they did not give any kind of good immune response. So they were not, even now, vaccine research is going on world over. Next tool, which is a very good tool, is pre-exposure prophylaxis. It's a new tool to fight HIV. So what do we mean by pre-exposure prophylaxis? Pre means before. It's just a simple English word. Exposure is when a fluid containing microorganism, which is HIV pathogen, it comes into contact with the mucous membrane or non-intact skin. It means, and then prophylaxis is an action taken to prevent infection or disease. So exposure, before that exposure, if you have taken some action, it is pro-exposure prophylaxis. PrEP is under research also. There are many formulations that are coming up because people may not like to take medicine every day just to prevent a disease. They are not patient. They want they don't want to take anything like a vitamin or something. But there are so many formulations that are coming up. There are capsule one. There are PrEP that can be used under the skin also. There are patches that are being tried right now. I'll give you just a little bit information about the injectable PrEP, which is given 2 months rather than daily pill. You do not have to take pill every day. It will be given in 1 injection in 2 months. And that is why it becomes important. You can be adherent, at least once in 2 months is easier for people to take. And a drug called Aptitude, it has been approved by US Food and Drug Administration, and it is to be used in at-risk adults and adolescents weighing at least 35 kg for pre-exposure prophylaxis to reduce the risk of sexually acquired HIV. So we are very particular about saying this drug has been tested only for sexually acquirement of the disease and not by injection drug or mother to child. So those who have risk because of unprotected sex, they would be eligible for this particular injection. But this is not in India as yet. Now coming down to oral PrEP, it's a new tool to fight HIV, and it uses antiretroviral medications. So the same tablets that are used for HIV infected individual, in different doses, these modalities have been tested. So some of the antiretroviral medicines that can be given to people who are at risk of HIV infection, but they are HIV negative. So anyone who has multiple partners, who has unprotected sex, who who has an occupation where you are having sex, lot of sex work you are doing. In those, they are the people who are at risk of HIV infection. Anal sex is another risk where a person is at risk of HIV infection, and for them, use of the prescribed antiretroviral is useful in preventing HIV infection. So PrEP can be used in a comprehensive prevention plan in which adherence to PrEP, like the way adherence would mean the way a doctor, a healthcare provider has asked a person to take that tablet at a particular time, with food, not with food, on empty stomach or not, when, where and why, how they have to take. That is called as adherence and compliance. So that is extremely important. Then they should also use condom with it, and because PrEP cannot prevent other sexually transmitted diseases. Yesterday, madam talked about many of the diseases also, syphilis, she talked about chlamydia, gonorrhea, all those diseases. PrEP only works against HIV, not against other STI. For that, we always ask people, if they are taking PrEP, they should use condom also, and they can also use other risk reduction methods. Oral PrEP has been found to be extremely good because it has 99% efficacy for acquiring HIV, not to acquire HIV from sex, or among injection drug user, the efficacy is 74%. So you have 74%. If you are an injection drug user, you are on PrEP, you have 74% chances of not acquiring HIV. While if you have a sexual risk behavior, then if you are taking on PrEP, daily PrEP, then you have 99% protection against HIV. Then what do we call? Is PrEP a vaccine? No. PrEP is not at all a vaccine because it does not work the way vaccine does. Vaccine works on your body for the whole life or for a particular whole period. Either sometimes you have to take booster after 5 years or 10 years, but it works on your body for several years, and PrEP does not. PrEP has to be taken as pill, it is taken orally, and it has to be taken daily. It goes into, it has to be the PrEP, some level of PrEP should be in the bloodstream every time so that it can stop HIV from spreading in the body. So if you do not take PrEP every day, then this medicine would not work for a person who has risk for getting HIV. So what is the rationale behind doing this study? Because you saw my title, the title of my talk was PrEP among MSM and transgender women. So in India, HIV prevalence among MSM and transgender women is 2.69 and 3.31%. So these are very high. You know, I will again go back to the national prevalence. National prevalence is, in general population, it is 0.22. And here what we are seeing, 2.69% and 3.13%. It is very high. And then India has demonstrated success in reducing. There has been a decline. Again, I had talked in my previous slide that the decline for HIV incidence is 56 to 66% in past 10 years. But what has happened in MSM and transgender women? I'm not talking about sex workers. Female sex workers also are at risk, but we are seeing I'm sorry, we don't have a blackboard or something, but I can just, if you think the peak goes, and then in sex workers, the peak has come down now. So intervention of condom promotion among sex workers has worked. But in MSM and transgender women, what has happened? The peak has gone up and then it has stabilized. So you saw a plateau in yesterday's slide when madam was talking about the HIV infection itself. So that is how HIV prevalence has plateaued, which means it is not going down. Why it is not going down? There are some hidden population which is not getting any kind of information. population who don't want to come out and use condoms and the available existing prevention options probably, and we have to do something for this stabilized epidemic group. That is why this key population is actually a vulnerable population right now, needing some kind of prevention intervention. So PrEP becomes an opportunity for accessing HIV testing, because when you give PrEP, a person has to be tested for HIV because eligibility is HIV negative. So first thing is you open a window for people to come and get HIV test done. So naturally, those who are found HIV positive, they will be immediately linked to the ART center so that they will start getting medicines. And those who are negative, or if they have other sexually transmitted infections, again I have to inform, free treatment is available, and most of the STIs, sexually transmitted infections, are treatable, curable. So that also is done. So with PrEP, window of opportunity are many now. HIV testing, treatment for linking with ART if they are found HIV positive, and then STI testing, and then treatment of STI also. Again, you are reducing the risk of HIV infection because STI would go down. But what are the programmatic needs? How can it come into public health system? PrEP. We do not have any guidelines right now in the country. NACO is in the process of developing those guidelines, which means how there would be delivery of PrEP, how would the PrEP the tablets would reach the vulnerable population, what all has to be done, how the clinics have to be, how the capacities, how infrastructure has to be built. Nothing is known right now. And the action that we can take is to do a demonstration project. And why demonstration project? Because clinical trials, I'll show those slides also. In clinical trials, the PrEP tablet has been found to be highly efficacious. I quoted also 74% and 99% efficacy in reducing the transmission, in protecting people. So that's the kind of efficacy. It is much more than any other vaccine also. But then we also need to understand whether people will take it or not, what will happen in real life scenario. So the current situation, we have taken up this responsibility of doing this PrEP demonstration project, which might contribute to the development of guidelines for effective PrEP delivery in vulnerable population. So in 2013, WHO brought out a framework for country-level protocol development for PrEP demonstration projects. So how and why PrEP demonstration project should be done was given. So let us understand what is a demonstration project. So what happens when we do, see, if any modality, any drug, any injection that comes into public health system or in the health system itself, whether from private or from government also, the steps are like you do preclinical study, then you do clinical trials in which you do phase 1 trial, phase 2 trial, and phase 3 trials. The phase one, everywhere objectives are different, and it is, I'm not going to talk about it, but they are very interesting and very detailed ones. But they focus on phase 3 trial. Phase 3 trial always gives you the final efficacy. It's the strongest evidence in science for any drug or any vaccine or any injection, any kind of tool, medical tool. So it is called as randomized control trial, RCTs, and somebody might have talked about it. So the phase 3 trials give you the final result, final outcome, whether the product would work or not work. And after doing that, so it is called as efficacy research. And now that you have that tablet or a vaccine ready, scientists have given it to you, doing the huge RCT, then it has to be implemented in the country, isn't it? That is called as full-scale implementation. But before you implement, there is like a lot between cup and the lip. People may not like that drug. People may not like to go where the drugs are being given. People may not like even the smallest side effect. People might still want to hide. They are embarrassed to come. So many things. So you have the best efficacious product in your hand, but there is no acceptance in the community, no acceptance in the end user. Then what is the use? And that is why demonstration projects are given. That is why WHO has talked about demonstration project. They demonstrate, that's the second bullet, they demonstrate that something which proved to be effective in a controlled trial can actually be implemented in setting reflective of real life and real health system. So what we are doing, we are trying to simulate a real life system when we are doing a demonstration project for PrEP tablet. So it is an important step when intervention in question may have significant challenges in implementation. And definitely anything like even otherwise prevention is very difficult because you do not get outcome. You are not sick and you take a tablet. When you have fever, you take a tablet and you are okay. Then you feel, oh great, this tablet was very good, this doctor was very good. But if somebody gives you a preventive tablet, you do not know, because for years to go, for your whole life, you will not get that disease. So you do not know whether I'm taking, why should I take it? It gives me a little bit of headache or stomach pain sometimes. Still, but it is saving you from a big disease. Like when you get vaccine, you take injection and you get a little bit of fever. Right now, even for COVID vaccine, people have had so many side effects, but you have taken it. So that is how you think about prevention. That's how you have to think about prevention. But COVID was like, it was very immediate kind of thing. HIV is not like that. HIV you can acquire after years together. And for that you need to have prevention for your whole life probably. So it's very difficult. And that is why we say that important step when the intervention in question may have significant challenges. There can be many challenges. People will not take it. So what do we do in demonstration project? We recruit people who are at risk of acquiring HIV. We do HIV testing. Then we supply oral PrEP drugs to them. And then we also do adherence counseling, because if it has to be taken daily, then it has to be taken daily because the drugs have to be maintained in the blood. Some level of drug has to be there in the blood. Then we also monitor the adherence, whether they have taken or not. And there are blood tests which tells us, because people can just lie. They just come and tell us we have taken, they have not taken. And then we can, for a very good product also, we will say, no, this is not working, because those who have not taken and they are having unprotected sex, then they will seroconvert, they will get HIV. And then we will say this drug did not work. And that is why in demonstration project, at least we also test the drug levels. Then we also test HIV status and safety. And then there are additional component of adherence counseling by the doctor, by the counselor, by the pharmacist to maximize adherence. Most of the time, what do we want to find out in demonstration project is, it is to enable all the countries to learn enough about implementation issues. So whatever problems we may face in real life, we get to know in demonstration project. And then WHO also extract those information and the final main guideline for PrEP delivery, because it should come. People need it. People are at risk. They want it also. So it should come, and WHO would bring it out. So two tablets have been approved as oral PrEP. One is Truvada and the other is Descovy. Truvada has emtricitabine and tenofovir. And again, Descovy has emtricitabine and the lower dose of tenofovir. Then what is the gap? Do people know about PrEP? Not enough of the healthcare providers know about PrEP. So doctors, if you go to doctor, they might not know about PrEP. They do not know that PrEP can reduce the risk of sexually acquired HIV by 99%. They do not know about reduction of risk in injection drug users by 74%. And we have also found that 1 in every 3 healthcare providers, they have not heard of PrEP at all. So how would they talk about PrEP? How would they prescribe PrEP to the people who actually need it? And above that, how will they monitor and help people who start taking PrEP? Adherence is extremely important. I have been talking about it, that PrEP reaches maximum protection for HIV for receptive anal sex at about 7 days of daily use. So at least for a week, they should be using PrEP tablet. They should be taking PrEP tablet if they are into receptive anal sex. And for receptive vaginal sex and injection drug use, the period is 21 days. So 21 tablets they should have taken. For insertive anal and insertive vaginal sex, we do not have any data right now. Adherence to PrEP, I have been talking and repeatedly talking about it, that it is extremely important. So I will not again talk about it, but there is additional research which is going for the trials that have been taken. IPREX study was a big trial. It indicated that 7 doses per week was likely associated with 99% efficacy. So at least 7 days they had to take, then only there was some kind of protection. So how does PrEP work? So I don't know whether all of you know about it or not, but the moment you get HIV, yesterday Dr. Pawar briefly touched upon this, that the moment you get HIV, that doesn't mean immediately you will test HIV positive. So virus needs to spread throughout your body, and this takes at minimum of 3 days after exposure. So even the myalgia or the mild flu-like symptom that you get, it will come after 3 days. So this is the window of opportunity for PrEP. If a person who is constantly getting exposed, is constantly on PrEP, this 3 days period will be used by the PrEP. So during this time, PrEP may be able to stop the spread of HIV. And that's why everyday PrEP is important. Who all need this PrEP most? People who are sexually active MSM, bisexual men who do not have HIV. Then sexually active heterosexual men and women also can take it without HIV if they want. Sexually active transgender persons without HIV, they also can take it. Persons with HIV who injects drugs, without HIV who injects drugs can take this. So persons who have been prescribed non-exposure, non-occupational post-exposure prophylaxis and report continued risk behavior. So there are occupational risks also to the nurses, technicians sometimes, and if they have occupational risk. So if for emergency, I had said post-exposure prophylaxis, which is PEP, is there. But you do not want PEP all the time because it has other regimen. So you can always take PrEP if you feel that you are constantly on risk. So those who have anal or vaginal sex in last 6 months, they can take PrEP. If they had HIV infected partner, they come to know that they had sex with HIV infected partner, or they do not consistently use condom. Every time they are not using condom, or if they have been diagnosed with STD in the past 6 months. Then for IVDU also the PrEP is recommended if they had HIV infected injection partner, or if they continuously share needles, syringes or other equipment to inject drugs. People with HIV, that means HIV infected persons, people with renal insufficiency, for which there are tests available, and we do those tests for every person, every potential participant who comes for PrEP, and people who have hepatitis B serology, they cannot participate in PrEP, or they cannot take PrEP. Now I will talk about the PrEP demonstration project that India is conducting. The evidence PrEP, as I said, the RCTs are very important, and you see first column, men having sex with men, then heterosexual men and women, injection drug users. All these 3 trials were conducted with PrEP, and the effectiveness estimate was 99%, 99%. In injection drug users, it was 74% and 84%. Please look at the last column here and look at the red lines. The effectiveness of oral PrEP is highly dependent on PrEP adherence, which means if it is to be taken daily, they have to be taken daily. All the great trials that have been done, they have shown great efficacy, but they have also said that they should be adherence, and that is again an implementation issues. You must be having lot of relatives and your patients also at home who just say, no, I will not take medicine. So that's how it is very difficult. Adherence is extremely difficult in such cases. So looking at our study, we are trying to study the feasibility of oral TDF containing PrEP administered once daily orally to men having sex with men and transgender women in India. And the design is called as prospective multi-cohort demonstration project using observational study design. And we are conducting this study in Jalandhar and in Pune. In Jalandhar, it is community-based setting, and in Pune, it is clinic-based setting. Here, I will stop a little bit more just to explain this. As I said, demonstration projects shows that how the drug has to be delivered, how people will like it, and whether they will like how they would want it. So we have used two settings. We are using two settings. Community-based setting is where the whole community, which means transgender women or MSM, they are running the clinic. The clinician, the counselor, everyone is from the community, and they are running this facility. And in clinic-based setting is just like any other clinic. In Pune, we are using that setting in camp area. At both places, we are providing PrEP to eligible TGW and MSM. The sample size is 800 MSM and TGW at substantial risk for HIV infection, meeting the study inclusion criteria, consenting to participate in this research. And 20% of the total study has to be transgender women in this particular study. We have multiple aims. Yesterday and then the day before, Dr. Merchant and Dr. Pawar, all of them have talked about many issues, and we have tried to look at we are trying to look at all the issues, although our aim is to understand implementation of provision of daily oral TDF containing PrEP to this particular population. But we are also looking at the percent retention, whether people will come and take the medicine, they will come for the follow-up, for all the tests that we need to do. And then also we are looking at the acceptability of provision of daily oral PrEP, and then to study the adherence of oral TDF containing PrEP along with existing HIV prevention options like condom use, having protective sexual behaviors and all. And other objectives are to study the usage of other prevention options, to evaluate change in sexual behaviors and reported mental health issues in response to PrEP. Because if you are taking PrEP, you feel a lot protected. So the mental health issues should also, one area is now safe, you are safeguarded. So we are trying to study that also. And then we are studying the willingness to pay for PrEP at subsidized cost. Because you are not a patient, you are HIV uninfected, but you need this, but the medicines are extremely important. So would you be able to pay us what kind of subsidized cost you would need? Maybe you will say we need it free. And then to study the facilitators and barriers of PrEP use among this study population. Why they would use it and why they would not use it. What solutions are there? We are expecting to find out from this particular study. So currently, till 17th February, we have screened, in Pune, we have screened 403 MSM and TGW, enrolled 257, and we have done follow-up of 473. At Jalandhar site, we have enrolled 320, we have screened 321, enrolled 262, and we have done follow-up for 459. This has been done during the COVID lockdown periods also. So total enrollment up till now is 518. So this enrollment is still open, it's going on. This is the tablet that we are providing. The trade name is Tenvir EM. It is given by Cipla, and the film is coated tablets containing tenofovir 300 mg, emtricitabine 200 mg as active ingredients. It has to be taken once a day with food at the same time each day. So if you are taking it in the morning, in the afternoon, you have to take it every day at the same time. It has to be taken every day and not just when you think that you are exposed to HIV. This is counseling that we do. So you cannot take it like that. You have to maintain that level in your body, and always combine the use of PrEP with condoms and other safe practices to safeguard yourself from other sexually transmitted diseases like chlamydia, gonorrhea, syphilis, and so on, so far. One. Then inclusion criteria, who all can participate. Like even if they are MSM and transgender women, there are some clinical parameters. They have to be those have an HIV positive sexual partner. If somebody comes and tells us that their partner is HIV positive, then that person can, because that there is a lot of risk. So that person can participate. If they have a recent bacterial STI, or they have a high number of sexual partners, have a history of inconsistent and no condom use, they are engaged in commercial sex work, and then they have to be major, not minor. So these are the people who can participate in this particular study. Our exclusion criteria is if they have hepatitis B surface antigen positive, so they are excluded because they have different biological risk. Then if they are anti-HCV ELISA positive at screening, they cannot participate. Those who have known or reported hypersensitivity to any medicine in PrEP regimen like tenofovir and emtricitabine. So if they are allergic to any, they report it, they cannot participate. If they are currently taking PrEP, people are privately taking PrEP, or they are sometimes enrolled in other intervention project, ART intervention project, they cannot participate. And if there is some condition which a doctor or the clinician at the clinic feels that it will not be good for, it will be unsafe for the participant, then the participant is asked not to participate. So what we do when a person comes for participation, we screen them. And all this is done free of cost. We do HIV testing, we do HBsAg testing, HCV testing, we do liver function test, and we do serum creatinine test. This all gives us information about hepatitis, HIV, HCV, liver problems, or any kind of kidney problems. And if they are found eligible, sorry.
I think somebody mistakenly unmute. Yeah, I'm so sorry, Dr. Seema. Yeah, please carry on.
Okay. So if they are eligible, they get enrolled. If they are not eligible, we just don't leave them alone. We refer them to the right physician, and if required, if they are HIV positive, then we link them to the ART center so that they can be given treatment for HIV also. We do a number of lab investigations at enrollment, at 3-month visit, 6-month, 9-month, and 12-month. So it is a 1-year study where people participate for 1 year, and we closely monitor their serum creatinine level, renal function test, and we also monitor whether, because they are at high risk of HIV, so we also do HIV testing for them all the time. Then other things that we offer in this particular study, we do diagnosis screening for sexually transmitted diseases, and we give free treatment for sexually transmitted diseases. We give free vaccination for hepatitis B. In Pune, we give it at Armed Forces Medical College because you need an hospital setting for that. We also talk about condom use because PrEP does not provide protection against gonorrhea, chlamydia, and all. And that is why we keep on talking to them that not to get these STDs, and these STDs, if they get these STDs, then we treat them also. About the long-term harmful effects of health, PrEP does not cause any short or medium-term safety concerns. So it is a safe drug. And if people without HIV and have taken PrEP for up to 5 years, up till now, no significant effects have been seen in them. And since tenofovir and TAF are eliminated by the kidney, PrEP should only be used in patients without renal impairment. And that is why you see every time we are very particular about serum creatinine test. So anytime there is some kind of change in that, we are very concerned and we want to inform the program about it. But up till now, we have enrolled so many patients, we have not got any elevation in serum creatinine. So it should be co-administered. It can be co-administered with other drugs that are eliminated by kidneys, like acyclovir, ganciclovir, valgacyclovir, and so on and so forth. And drugs that decrease renal function may also increase serum concentration of tenofovir and emtricitabine. So that is one of the effects that we see. But still, it is not a problem. What side effects we are seeing in our participants is most people do not have side effects while taking PrEP. Initial in the beginning, sometimes they have talked about upset stomach, headache, vomiting, and loss of appetite. So these we have seen, they usually fade during the first month of it. And we always tell them, if you have anything severe, you have to call us immediately. But it has been a year or so, we have not heard any kind of emergency of that sort. So no, not an adverse event which is related to this. And this study has also data safety monitoring board, where external members are monitoring the study also. When to discontinue the PrEP? When you are HIV positive, you have acute HIV symptoms, you are not taking the drug regularly, you have some kind of renal disease, or you have low HIV risk. Earlier you were a sex worker and now you are not into it. So then also you don't need PrEP. Or if you are just unwilling, you don't want to take it. So anytime you can discontinue this. The study is still ongoing at Pune and Jalandhar. So anybody who is interested can approach us. So this is the contact number. This one of the community group, they helped us and they posted it in the Instagram and Facebook and everywhere about this. So anyone who wants to participate in this study, anyone known to you who really wants to get PrEP, they can always approach us. The quest is going on. You see this whole group of preclinical, phase 1, phase 2, phase 3, phase 4, delivery system. Everything is still ongoing to combat AIDS. These are some of the references if you really want to learn a little more than what I have talked about. You can always take it. I can share it with Professor Renu. Thank you very much. If you have, I'm ready for questions, and thank you for your patience.
Thank you so much, ma'am. Now I will request Shivani Jadhav, the program coordinator, to open the session for discussion and questions.
Anybody can raise their hand for unmuting to ask questions.
I think too heavy.
Ma'am, Rajiv has raised his question. Rajiv, you raised his hand. Rajiv, you can ask your question.
All right, thank you. So hello ma'am. So my question is, like right now we've also received some news about like some people being querying of HIV completely, like who were infected with the virus, So as you talked about like the tracing the history and timeline of it from 90s till now, we have PrEP and other treatments as well. So what do you think is like the future trajectory for this virus? Like given we are living in pandemic time, do you think there will be like one short solution as well for this disease?
Yeah, yeah, good you have brought this up. This cure, that there is quest for cure also. And these patients, this patient had leukemia, and there was replacement, stem cell replacement is done for them, and at that time a cure has been seen. Earlier also it was seen. So it is actually for a particular disease like cancers and all. When this replacement is done, there has been a cure for HIV also, because there was no detectable level of HIV. So that cure that cure is one area of research which is going on. So they always qualify that. They qualify it with that it is for the leukemic patient that they have got this. The other cure is looking at the latent virus, shock and kill. Latent virus are viruses that remain hidden inside the body, and they hibernate, and they are actually, because of them, the cure is not possible. So the other modality that scientists are looking at is to shock those latent virus, and they should come out, and then they should be killed. The shock and kill therapy is thought of. So sometimes you might have heard of intermittent ART also. So that modality is being tested. But up till now, no trial, as I talked about RCT, randomized controlled trials and all, which can really give us the efficacy of any modality, that has not come up.
Thank you, Ms.
Thank you, ma'am. Do we have any more questions from the participants? We'll just wait for a minute, ma'am.
Okay. So can I say something?
Definitely, ma'am.
Yeah. See, I want to leave a message. All of you, all the students who are sitting here, all of you are leaders in your own field right now. And this is,
Is she saying something?
I'm working for a national institute, and I'm trying to look at the control of HIV. So you have heard about PrEP study, and I would just request you to spread the word. That's all. You are from all over the country, I know, but if the study is going on in Jalandhar and Pune, and somebody wants to take advantage of this, they are welcome. So if you just spread the word, that would be really important, and that is what I expect from all of you, and I'll be thankful for that. Thank you.
Thank you, ma'am. Ma'am, I also wanted to ask if anybody inquires about a point of contact, which should we give? There should be an email ID or any phone number. If that would be great if you share with us.
Yeah,
So-
I will send that.
All right, ma'am.
Even the poster has the phone number and email address. Everything is there.
All right, thank you, ma'am. Ma'am, there's a question in the chat box. There are plenty of conflicting information concerning the risk of contracting HIV or STIs through oral sex. Could you please elaborate on that?
No, oral sex, it is not conflicting also. It is the oral sex risk of acquiring STI is very much there, but the risk is low. That's all. But then that is why use of dental dams and all is recommended. So why should you say it is conflicting? It is not conflicting. It is very much there.
Shubham, I hope that answers your question. If not, you can unmute yourself as well. All right. Thank you, ma'am. I think those are the questions from our end. However, if we receive any more questions from the participants, we'll definitely get those to you for getting clarified. With this, I would like to take the opportunity to give the formal vote of thanks to you, ma'am. Firstly, thank you for taking out the time from your busy schedule and giving such an elaborate presentation to the participants. The information was entirely backed statistically, and also I myself learned something new from the presentation. So thank you, ma'am, for taking out the time to educate our participants from a medical research point of view on the topic. That is happening. That is one of the sessions that we have had in this week for when it comes to medical aspect of community members in the community. Yes, Shubham, I was. All right. Okay. So that answers your question. Thank you. So thank you, ma'am, for educating our participants about this aspect. We thoroughly learned a lot from the session today. So thank you so much, ma'am. And we'll definitely get in touch if we have any more questions or we require any information from your end. And we'll be definitely sharing the contact information that we'll be getting from you.
Thank you. Bye.
Thank you so much, Dr. Seema. Thank you very much.
Thank you.
Have a great
evening also.
Yes, of course. And I think we will surely be getting questions because it was basically the statistical base, as Shivani also said, and we were also looking at the PPT that you have shared. So might be it will take some time for them to understand the whole thing because there are some students who are doing research in this particular area. So maybe we'll come back to you soon with their queries.
Sure.
Yeah, thank you. Thank you very much, everyone. Have a great evening. Bye-bye.
Bye.